Hello, everyone, and thank you so much for coming to this clinical cardiology conference. It is an incredibly important conference for Mount Sinai. We've enjoyed doing this for so many years, and you're all quite welcome. Thank you for joining us. I'm going to be speaking a little bit about the crisis in COVID-19 at Mount Sinai Health System. And all along the way, I will give some description of the financial implications of all of the items that we speak of today. So Mount Sinai Health System is 8 hospitals located throughout New York City and Long Island with greater than 4.1 million annual patient visits, greater than 410 ambulatory practices, over 42,000 employees, affiliated with one school, the Icahn School of Medicine at Mount Sinai. This slide provides quite a timeline for us to look at, showing how the crisis unfolded from the time that when we all became first aware of COVID-19 through June 8th, when we began elective surgical procedures again. So beginning in early January, the health system became aware of COVID-19 along with everyone else, and we began our first internal drilling and emergency operations center preparations. On February 7th, we had our first COVID town hall. On March 5th, we converted our first ICU to a COVID ICU with negative pressure in all of the rooms. Following the first case that was diagnosed in New York State, it was an ambulatory couple of physicians actually who were tested at Mount Sinai Hospital on February 29th. By March 9th, we had our first Mount Sinai Hospital COVID-19 admission. And by March 15th to 17th, we'd expanded our laboratory to do in-house testing for both viruses and antibodies. We'd imposed visitor restrictions, universal masking, contingency standards for N95 respirators, and we'd halted elective procedures. So at that point, economically, the revenue had stopped coming in because there was very little in the way of elective procedures. Although we were well reimbursed for the COVID patients and there was some government support, it is overall a less margin generating activity than what you see with elective surgical volume and elective cardiac procedural volume. By March 22nd, New York was on pause. By March 30th, visitor screening for labor and delivery, and we liberalized N95 distribution, meaning that our expenses for PPE were dramatically increased as we had to distribute as many N95 masks as we could have, really rarely ever having more than 2 or 3 days supply on hand. We did major construction in our lobby spaces to create non-traditional space. And also, I will note that on April 1st, we opened tents in Central Park in collaboration with an outside organization that had the capacity to treat up to 68 patients in hospital tents that were normally intended for the third world. By April 4th to 7th, we were at the peak with over 2,000 patients in the health system, over 700 at Mount Sinai Hospital. By April 8th, we'd opened up a COVID-19 palliative care unit because we had so many patients who were so ill in the ICU that some of them had moved into a palliative care status. By April 14th, we actually opened our lobby for some care also by the same team that was taking care of patients in the tent, but we also were able to reopen our first non-COVID unit because the non-traditional spaces were able to decant. So what were our major challenges? Increasing capacity. Critical care capacity required we have more negative pressure rooms than non-traditional spaces. It involves switching most of our ambulatory care to telemedicine. Workforce management, we had to expend a lot of dollars to fix the supply chain for PPE and for ventilators, as we'll get into. Staff training and engagement. Communication was probably the least expensive because that's mostly electronic. Redeployment of staff away from areas such as psychiatry or radiology and pediatrics into the adult hospital. and moving to a team-based model of care to support our nurses. In-house testing, ventilator acquisition and management, extracorporeal membrane oxygenation, and increasing the level of therapeutics all required additional expenditures. And then, of course, our own in-house testing was necessary so that we could more appropriately use personal protective equipment, and doing this in-house decreased the turnaround time to under 12 hours from 6 to 7 days for external assessments. Patient placement was very challenging, increased our expense because it was difficult to get patients out of hospitals to nursing homes or LTACs, and staff engagement was always a challenge because of the factor of our staff being, frankly, appropriately frightened by this very challenging situation. The curve flattened in New York in the middle of April, and by May we were down to very manageable levels, and by June there were less than 10 patients at Mount Sinai Hospital. So that actually worked out very well for us, although the decline from the peak was very, very protracted, but the staff did very well. Now, we also had to work very hard to increase ventilator capacity using innovative techniques such as non-traditional ventilators. We used anesthesia machines, transport ventilators, and specialty ventilators, launched a centralized assembly, testing, and distribution of devices for the health system. We probably spent in excess of $10 million in purchasing extra respiratory devices in our health system. We also leveraged our simulation laboratory to facilitate innovations such as upgrading home ventilators, which were a several hundred pool backup for the health system in case we ran out of critical care ventilators. And we also developed a ventilator splitting protocol, including 3D printed valves. ECMO was prepared and ready to go. We did use it on a certain number of patients. The outcomes were not wonderful in those patients, unfortunately, but we believe it's a very important, albeit expensive technology to have for patients who have end-stage lung disease that may either recover or potentially be referred eventually for lung transplant, but obviously recovery pathway is the desired outcome. Now, this is getting towards the end. You can see this positivity rate for tests. Originally, we're about 2/3 positive at Mount Sinai Hospital and elsewhere in the health system because we were only testing sick patients in the hospital. But as we began to test our community and others who are ambulatory, we see that the testing positivity rate decreased to consistently in the 1% range, where it has remained. In terms of treatment recommendations, we additionally had a lot of expense related to creating a process of convalescent plasma administration. These are data on our first 39 patients showing improved survival. And the health system probably has one of the largest experiences in the US with over 550 patients transfused. Very expensive and logistically challenging to set up a convalescent plasma program, but we felt it was essential. Antivirals in the form of remdesivir are not really easy to obtain initially, but over time, with allocation and equitable prescribing, we were able to best manage within our population. And we did SARS-CoV-2 directed antibody therapy, as I noted, and clearly anticoagulation was a huge benefit to us. This is the anticoagulation slide showing that there was improved survival. These are data from Mount Sinai itself showing that early anticoagulation is associated with decreased progression to intubation and also decreased mortality. Bleeding rates were low but marginally higher with therapeutic anticoagulation compared with prophylactic. This is the key to the economics. The absence of elective surgery during the middle of March through the middle of, really the middle of May, and then a gradual increase until we were back to near normal levels, really from July, although there's still some recovery that has occurred in multiple areas over the months of July through September. So I want to end by thanking the healthcare workers at Mount Sinai. They were absolutely tremendous. Our cardiology team dropped everything else that they were doing and they became critical care physicians. They use their anticoagulation expertise to change the course of care for COVID patients, potentially not just at Mount Sinai, but worldwide. And we're very proud of what the team was able to do. Several $100 million were expended on this process, and in the absence of federal funding, this would have translated to several $100 million of loss for the health system. We do not know exactly where we will end up after federal support, but suffice it to say that managing the COVID crisis was extraordinarily expensive, and ongoing expenses continue because of reduced capacity related to the needs for social distancing, fewer people in their holding areas, conversion to partial telehealth, and of course, not complete return of all elective procedural volume related to the ongoing nature of the crisis and the fear that we have in our patient population. Thank you so much for listening to this introductory lecture.